I'd like to welcome you to the Frozen Shoulder series, and in part 6. So in this presentation, we're going to be talking about 4 major areas of treatment: NSAIDs, or non-steroidal anti-inflammatories, steroids, manipulation under anesthesia, and physical therapy. So the first category of traditional treatments is NSAIDs, such as Advil. Advil is effective in reducing acute pain and swelling, but it's important for us to understand that frozen shoulders are chronic in nature. They're long-standing, and therefore NSAIDs don't work particularly well. Steroids can be divided into basically 2 categories: oral steroids and steroid injections. The orals can be helpful with pain up to 6 weeks. Frequently they don't help at all, and there can be significant and unwanted side effects. Steroid injections, on the other hand, takes away some of the acute pain some of the times. Frequently it doesn't seem to help at all. Its effect is short-term, it's rarely useful on its own, and it does have significant and unwanted side effects as well. One of those being the increased possibility, of tendons avulsing from the bone, or the tendons being pulled apart from the bone, and that requires surgery to repair. Our next category is MUA, or manipulation under anesthesia. And as the name implies, you are put out under anesthesia, and then someone comes in and manipulates or jerks your shoulder. That's done in the attempt to break the adhesions that are in the shoulder joint itself. Sometimes this has to be repeated. Every time it's done, it has to be followed by intensive physical therapy. There are some risks: fracture of the arm, tendon rupture, brachial plexus injury, and when we're talking about that, we're talking about the nerve, the artery, and the vein. That's what the brachial plexus is. When you're jerking that shoulder around, when you're under anesthesia, there is that possibility, it has occurred, where the nerve, the artery, and the vein can be compromised. That's a serious injury. There are also risks associated with being under anesthesia. MUA is not something I recommend, except in extreme cases. And there are very, very few people who don't respond to care and require MUA. Dr. Stetson is an MD. He's an orthopedic surgeon. And his statistics show that traditional physical therapy gets 50% of the patients better, and 50% of the patients who try physical therapy go on to surgery. So basically half the people with frozen shoulders get surgery. Those are terrible statistics in my mind. They're far less than what we're able to achieve. Dr. Neil Asher is an osteopath from England, and he states the current medical approaches have not proven to shorten either the duration of symptoms or reliably improve the range of motion of frozen shoulder patients. Dr. Asher is someone to listen to. He is a pioneer in the treatment of frozen shoulder. I have studied with him. I am certified by Neil Asher in his approach. We have found it to be a huge improvement over traditional approaches, and our results show that. Is it any wonder that 70% of frozen shoulder patients still have symptoms after 7 years? Here's a frozen shoulder patient, discharged from care after 3 months and 36 treatments. As you can see, her range of motion is still very poor. She can't sleep without pain. She wakes frequently. She still gets those twangs of pain deep in the shoulder when she bumps it against something. Most of our patients have been to PT first, and this is part of the reason why. Dr. Stetson is an MD. He's an orthopedic surgeon, and he says that 50% of patients go on to surgery if they're only treated with physical therapy. Well, we use physical therapy on our patients, but we also use a number of other techniques as well. And there's a reason why our results are so good. 90% experience very good to excellent results, and we're very proud of that. There is a better way, and we're going to tell you a great deal more about that in the next few parts.